Hello guys, welcome to our Sureshot series and rapid revision program. Today we are going to discuss about the physiology and its most important topics from the previous year examinations. FMG, NEETPG, INXD, these are the commonly repeating topics that we are going to discuss today. So let's focus on the discussion. Before we start, please do subscribe to this channel and share with your friends. And let's start. The first topic is the feedback mechanism. We have the two types of the feedback mechanism. One is the positive feedback mechanism and another one is the negative feedback mechanism. And also other type is also there, that is a feed forward mechanism. But let's understand what is the positive feedback mechanism and the negative feedback mechanism. So the positive feedback mechanism, when the mother is giving the milk, let's say the mother is giving the breastfeeding for the child. So while this child is sucking the nipple, so this will cause the reflex. What kind of reflex, guys? This will release the baby sucking will release the oxytocin in the mother. So this is the positive reflex that is releasing the hormone from the mother with this action, that is a positive feedback mechanism. What is a negative feedback mechanism? For example, let's say we're having that TSH, the thyroid stimulating hormone. What is the function of it? It will be producing the T4, the T3. So what it will do, usually it will be increasing its T3 and T4 levels in the blood. Once the T4 or the T3 is released and it will reach the normal point, what it will do, it will send the signals to the TSH to tell that please stop producing the TSH. So this is what the negative feedback mechanism. So the difference between the positive feedback mechanism is, it is positive feedback mechanism is pushing to do, the negative feedback mechanism is the pulling back to normal position. So that's how our normal mechanism of actions in the body, the physiology is maintained. That's how. Next, moving on to the next one. This is the commonly asked question from our inter 11th, 12th also. We have been revising this. This is the normal cell of our human body and their organelles. So let's understand each and every important points. Not going into the deep or not going into the superficial. We'll just understand important points only. So here you can see, we all know that mitochondria. What is a mitochondria, guys? It is a powerhouse of the cell. So the mitochondria is the powerhouse of the cell. It will be producing and maintenance of our ATP and energy production. And one question that will be integrated with your genetics or it is integrated with your biochemistry, what is that? The mitochondrial inheritance. What does mean by the mitochondrial inheritance? So the mitochondrial inheritance means one in the family, when there is a mother and the father, so the disease is transmitted from the mother to the son is known as the mitochondrial inheritance, because the only the woman or the woman fertilization will only the transmit the mitochondria, because the sperm will lose its mitochondria. So any mitochondrial inheritance from the mother to the children, it is transmitted, then that is known as a mitochondrial inheritance, especially mother inheritance only, maternal type. So what is the example? The most commonly is seen with the Melas syndrome. So this is a multiple systematic disease. It will involve your retinopathy, it will involve your encephalopathy, it will also involve the other systemic diseases, right? Next, moving on to the endoplasmic reticulum. What is the endoplasmic reticulum? Here you can see, this is the structure of the endoplasmic reticulum. Okay, this is the complex structure that you are seeing here. That is the endoplasmic reticulum. And endoplasmic reticulum is subdivided into the smooth endoplasmic reticulum and the rough endoplasmic reticulum. So the smooth endoplasmic reticulum does not contain any kind of ribosomes on it, but rough endoplasmic contains the ribosomes. What does the ribosomes will be doing, guys? It will be doing the protein production or the protein synthesis. Okay, it will do the protein synthesis and it will also participate in the protein folding. What about the smooth endoplasmic reticulum? Smooth S for smooth and S for steroid. So it will also participate in the steroid synthesis. Okay, and detoxification. So the detoxification is also done by the smooth endoplasmic reticulum. And some of the smooth endoplasmic reticulum will also have its role in the lipid synthesis. So this is what happening in the endoplasmic reticulum. Next, moving on to the Golgi apparatus. Okay, so the Golgi apparatus have the two ends. All right. So one is the cis end and another one is the trans end. What is this main function of the cis end and the trans end? Basically, it will do the post-transitional modification. Okay. This will do the post-transitional modification of the DNA and its enzymes. It's like a Google or the Amazon is packing its products after the sending it to the delivery house and packing and checking. All this will be done by the Golgi apparatus. Next, moving on to the lysosomes. Lysosomes are basically your suicide cells. Okay, these are your suicide cells, or we can also say as a death cells. And another thing that we also have, that is your peroxisomes. Okay, peroxisomes is basically it will be producing the free oxygen species. So the free oxygen species will help the neutrophils to kill the organisms like bacteria or any organisms will be killed by this free oxygen species or the free radical species. But if the peroxisome is deficient, this will turns into the disease known as Zellweger disease. So this Zellweger syndrome or the disease, this will involves your cerebrohepatorenal. All right. So this will involve your cerebrohepatorenal syndrome, peroxisomal deficiency. And next, moving on to the another one, that is your cytoskeletons. Okay, the cytoskeletons. Basically, we will be discussing the most important one. One is your dynein, kinesin, and your tubulins. So your tubulins is basically used in the tumor markers. Okay, tumor markers and the monoclonal antibodies. All this will be used in cancer studies only. And next, dynein is commonly associated with the rabies infection, and kinesin will also cause the retrograde disorders. How? What does mean by the retrograde disorders? For example, this is the cell body. Okay, and this is your myelin sheath and end plate, right? This is the cell body and this is your myelin sheath. All right, if the dynein is here, it will transmit its signals to here. So if the rabies infection is infected in this patient, so this will be traveled from the myelin sheath to the end from the cell body. So it will be attacked in the retrograde fashion. Same as the kinesin. So kinesin will also involve the peripheral. Okay. So this is what the basic pattern of the retrograde transmission of the disorders. Okay, next moving on to our most important thing, fluids and electrolytes. We all know that the 70% of our body is filled with the water only. So after that, this entire body system will be subdivided into the intracellular fluid and the extracellular fluid. In that, the 2/3 is the your intracellular fluid and the 1/3 is your extracellular fluid. And the extracellular fluid is subdivided into the interstitial fluid and the plasma fluid. All this will be the classification that is commonly known. But when we as a human beings born, basically we have the more of the extracellular fluid only. Okay, basically at the birth stage, your ECF is high. So gradually it will be decreasing by your age. And your ICF at the birth is very slow and very low, and it will gradually increase the by age of it. But at this point, this coinciding point, 8 to 12 years, it is commonly same in the every patient. So ICF and the ECF is equal at what stage, guys? At the 8 to 12 years of age. And at the birth, what happens? Your ICF is low and your ECF is high. This is at the 25 plus years. All right, this is how the body fluids is maintained. Next, body fluids, if is subdivided, what happens here? Your ECF contains what electrolytes and your ICF control what electrolytes. Let's see, your ECF contains the mostly the extracellular fluid is filled with the sodium, chloride, and other proteins. So this is basically present in the extracellular fluid. And in the intracellular fluid, potassium, phosphorus, and other small organic proteins is present in the ICF. All right. Next, how to calculate this? We have the specific pattern how to calculate this using the different kinds of the products that is available. Let's say when you want to calculate the total body water, you can use the deuteric oxide. So this is commonly used. The deuteric oxide is used for the total body water. Next, coming to the ECF, you can calculate the ECF with the using of the inulin. So inulin is not either secreted or either observed from the kidney. So it will be completely shown in the inulin. So inulin is commonly used for the ICF, and you can also measure the plasma. So how can you calculate the plasma? Using the Evans blue dye. So Evans blue dye will you estimate the how much plasma is present. So how to calculate the ICF? If you want to calculate the ICF, total body water minus ECF, you have to calculate. If you want to calculate the interstitial fluid, for this interstitial fluid, you have to calculate ECF minus plasma. So this is how we can calculate. Let's see what is the isotonic, hypotonic, and the hypertonic. So isotonic. How the isotonic is maintained, guys? Your body cell and along with the fluid that you are giving, both the osmolarity is equal. So the easy permeability between the your cell and the fluid is normal. Example, your ringer lactate and also your normal saline. And coming to the hypotonic, what happens in the hypotonic? Usually, when you give the hypotonic this person, your osmolarity of your body is high, right? But your fluid is very low. So this will lead to the semi-permeability between the fluid and the cell will cause the swelling of the cell. So the cell will swell. Example, your 4% of the 0.4% of the NaCl. So this is the example of the hypotonic. And next, coming to the hypertonic. Here you can understand easily the hypertonic, your osmolarity is more in the giving fluid. For example, let's say your 12% or the 9% of the NaCl. Okay, so the osmolarity in the giving fluid is more. What happens? This cell will shrink. So this is what happens in the hypertonic and the hypotonic isotonic fluids. All right. So next, moving on to the different types of the transport, and it's important. And another thing that we have to remember, what is the osmolarity formula? How to calculate the osmolarity formula? Using this way, you can calculate. Take the 2 sodium plus glucose by 18 plus urea divided by 2.8. So if you calculate adding all these values, we'll be getting the normal osmolarity. The normal osmolarity is around 295. Okay, milliosmol per liter. So this is what the normal osmolarity. Okay, next moving on to the types of transport. What is the types of transport? Let's see your active transport and your passive transport. What does mean by the active transport? For example, you are climbing for the up mountain hill. You are climbing for the up mountain. What you need, guys? The ATP, the energy is needed to climb upstairs, right? But when you are climbing downstairs, okay, you are going down, you does not need the ATP. So the simple difference between the active process and the passive process is the ATP is needed in your active transport, but the passive transport does not need the ATP. All right, let's see the difference here. This is your primary active transport. In the primary active transport, it is like an exchange. For example, a cell is trying to exchange the 3Na, okay, with the inside of the 2 potassium just for the ATP. Okay, you are just exchanging for something that is known as the primary active transport. How this is maintained? The 3Na is out. Okay, the 2 potassium is in just for 1 ATP. So this is the one pathway. The pump is present in the primary active transport. Next, moving on to the secondary active transport. This is commonly seen in your SGLT. What is this SGLT, guys? The sodium glucose transport is known as the SGLT. So the SGLT1 is present in your intestines. All right. And SGLT2 is present in your kidneys. You have the 2 kidneys, so that the 2 SGLT2 is present in the kidneys and the SGLT1 is present in the intestine. So this is what the active transport and the passive transport. And next, moving on to the passive transport. The passive transport have the 3 different types. One is the simple diffusion. The simple diffusion, there is no permeability between the membrane. So it is easily passing through, easily passing by. So there is no need of the other particle or other membrane that is needed for the energy. So this is commonly seen in your gases exchange with the using of the Fick's law. So this is the gaseous exchange that is commonly associated with the simple diffusion. The facilitated diffusion will be needed the carrier protein. So the facilitated diffusion will be needed the carrier protein that is commonly associated with the GLUT transporters. Like your glucose transporters that is associated with the facilitated diffusion. And the osmosis is usually does not need the any kind of energy, but it will be needing the special membrane to cross between the each and other membranes. And your examples are your endocytosis and your exocytosis. Okay, these are your examples. Next, moving on to the junctions. So in the junctions, we have to remember the tight junctions, the desmosomes, adherent junctions, gap junctions, and the hemidesmosomes. And hemidesmosomes, here you can clearly see the hemidesmosomes are connected with your basement membrane and your cell. So this is what the hemidesmosomes. Gap junctions is commonly seen in your heart. So the cardiac muscles, which will be most commonly attached to the each other myocytes with the gap junctions due to the help of your connexin. And the adherent junctions, which is also known as the cadherin junctions, is commonly, which is also associated between the connection between the two types of cells. Tight junctions is seen in your blood-brain barrier, and to that we can remember easily by the names of the occludins. So there is no occluding in between this. That's why it is known as an occludin or the Claudin. And the desmosomes is commonly present in your skin surfaces areas, and in the skin regions you can have the desmoglein or the desmoclein. Okay, these are present in the skin region. So this is what your gap junctions. Next, moving on to the action potential. So let's see what is the action potential. We all know that, right? The action potential is formed by the different types of the refractive powers. So for example, let's say your neuron, okay? Your neuron is at the minus 70 millivolts of the resting membrane potential. All right. And your sodium as same as that, it is also around the plus 70 millivolts of the resting membrane potential. And the calcium, which is very, very highest, which is around plus 130 millivolts. And your cardiac muscle and your smooth muscle, these both will be having the minus 90 millivolts. Okay, this is how the commonly having the resting membrane potentials are presented. And next, moving on to the how the action potential is formed. We all know that at the minus stage, the polarized state is always on the minus stage only. So if you want to increase the stimulus, what you are going to do, the depolarization is done by only by the sodium, right? The sodium is going into the inside, which will be causing the depolarization in the cell. And after a point, it will be reaching this, that will cause the repolarization. So your potassium is going out. So this will cause the, again, the polarized state will be maintained by the negative only due to the potassium ions are out. So the positive ions are going out from the cell, that will be causing the repolarization. What is this hyperpolarization? More and more. So the more and more potassium is going out. That's why it is having the hyperpolarization state. All right. Next, moving on to the nervous system. We all know that the microglia is your macrophagia of your brain. All right. And your squamosal is the myelin sheath. This is the myelin sheath for your peripheral nerves. And your oligodendrocyte, this is for the CNS myelin sheath. And the ependine cell, this will be used for your CSF layers. Okay, or your endothelium of the CSF fluid. Next, these astrocytes and your satellite cells will be used for the CNS neurotransmitters function. Next, moving on to the upper motor neuron lesion and the lower motor neuron lesion. Here you can see the upper motor neuron lesion is coming from the cerebrum to the nerve. Okay, here to the anterior horn it is coming. So from the cerebral region to the anterior horn it is coming. That is your upper motor neuron. And from the spinal cord to the muscle cell that is coming, that is your lower motor neuron. And how this is affected in the patients. In the upper motor neuron and the lower motor neuron. The basic difference between these two are the upper motor neuron is going to have the more and more reflexes. If the patient is affected with the upper motor neuron, he will be having the hyperreflexia. In the lower motor neuron, there will be a hyporeflexia. And also these patients will be having the Babinski sign positive. And the Babinski is negative in the lower motor neuron. And where the tone is mostly increased, guys, the tone is increased in the upper motor neuron, whereas the tone is decreased in the lower motor neuron. And also there is no atrophy is seen in this patient because the muscle is always in the active stage, whereas lower motor neuron having the hyporeflexia, less tone, so that will cause the atrophy of the muscle. And what is the common? And let's discuss the main pathways, like you say, the motor pathways and the sensory pathways that should be seen here. There are two pathways. One is your dorsal column pathway. Okay, so the dorsal column pathway is having the functions like fine touch, vibration, and your proprioception. So these three things will be present in the dorsal column pathway. But how this dorsal column pathway is trapped? Let's see this way. Okay, so usually this pathway is started from your cerebral region only. So it will be traveling from the cerebral region through the thalamus, and then it will reach the your medulla. So it will reach the medulla and then it will travel towards the spinal cord. This is how the one of the pathway will be traveled. And the other pathway from the other side, opposite side, for same again through your cerebrum, then thalamus, and then it will be going to decussate, and opposite side it will reach to the next opposite pathway of the spinal cord. So where this is happening, guys, this entire pathway is going to decussate at the this will be decussating at the medulla. So the decussation of the dorsal column pathway is occurring at the region of the medulla. So the problem here, if the patient is having the lesions in this side, we will be discussing in the next, the Brown-Sequard syndrome. Next, the other pathway, we have the spinothalamic pathway. So the name itself telling the spinal region, from the spinal region to the pathway is traveling towards the thalamus of the brain. All right. So how this is going to happen? So here you can see the first thing from the right side, it is going to travel towards to the left side of the place. Okay. Then from here, it is going to decussate. Okay. So this is your right side. This is your left side. So this is how the pathway. So here you can see the decussation from the left side, it is traveled and sharing the pathway from the right side of the spinothalamic pathway. And the right side is traveled towards to the left side and having sharing the pathway to the thalamus from the left side. So the decussation in this pathway is occurring at the stage of the spinal cord. Next, what is this spinothalamic pathway is going to give it, right? Giving, guys, the mostly the spinothalamic pathway is divided into the lateral spinothalamic pathway and the anterior spinothalamic pathway. And the lateral spinothalamic pathway is going to give the crude touch, sorry. So the lateral side is going to give for the pain and the temperature. And the anterior one is going to give for the crude touch and the pressure. These two is formed in the anterior spinothalamic pathway. And next, moving on to our disorder here. Here you can see this patient is having the Brown-Sequard syndrome. What does mean by the Brown-Sequard syndrome? So this is a hemisection. Usually, very rarely this kind of cases will be presented. If the patient is having the fracture or the bullet injury, that will be causing the one side of the one side of the spinal cord will be damaged here. So let's see that if the patient cord is movement, is the loss of the movement is seen on the same side of the cord damage. Why this is seen on the same side of the damage? Because here you can see the pathway in the dorsal column pathway is coming towards the same side only. So if it is damaged on this side, so this will be affected on the same side. And when it is comes to the spinothalamic pathway, the pathway is going to travel this side, right? So the patient won't be affected on this side. So it will be affected on the contralateral side. So the pain, temperature, sensation will be having on the opposite side. So this is what the presentation of the Brown-Sequard syndrome. So the dorsal column pathway is involved. So then it will be ipsilateral changes. So if the spinothalamic pathway is involved, then it will be showing the contralateral change of symptoms. So that is what you have to understand from the Brown-Sequard syndrome. Next, this is also one of the most important table you have to remember or the mug up, guys, because this is commonly asked in the hypothalamic nuclei. When the patient is having the anterior, so this is mostly responsible for the heat. So anterior hypothalamus is for your heat sensation, and the posterior hypothalamus for your response to the cold. So the basically your hypothalamus is for the temperature. So the temperature regulation is maintained by your hypothalamus, and the lateral side of the hypothalamic nuclei, which will be helpful for the feeding of the patient. So the orexin is the common function that is secreted here, and the suprachiasmatic, that is for your circadian rhythms, and we can also say for the melatonin, and that is useful for your melatonin. All right. Next, for the supraoptic one, this is for the ADH, antidiuretic hormone. And the paraventricular type, that is for your oxytocin. The ventrolateral preoptic for your sleep, and the mammillary bodies for the memory. And the ventromedial for the satiety. So these two are less commonly asked, but these all are previously asked questions only. This is the basic structural and the functional unit. All right. So the second thing that you have to know, these are the thick filaments and these are the thin filaments. What are the present in the thick filaments, guys? That is mostly your myosin, right? And in the thin filaments, that will be your actin. So these are the basic things that you have to remember. But if there is a muscle contraction, what are going to decrease its size? What are going to keep intact, remain in same? That is what the most of the questions will be focused. So the first thing that you have to know, the A band. So the A band, which is your mostly myosin, that is going to remain same. All right. So the A band will be remain same. And then coming to the I band, that is going to decrease its size. Okay. When there is a contraction, these are your I bands. So in between the contraction, these I bands will be coming together side. So that will cause the decrease in size. And what about the M line? So the M line is going to be the disappear. Okay. When both these lines come together, so that this M line will be disappeared. Okay. This is what the common changes will be seen in the structure of your muscle. So this is what happens. The A band will be remain same. The I band, the size will be decreased, and the M line will be disappeared. Next, moving on to the muscle contraction. How this muscle contraction is maintained. So when there is a ATP, so here you can see when there is a ATP is formed, so it will be going to attach to the myosin head. This myosin head is going to attach to the tropomyosin or the troponin or the other actin particle like troponin calcium is going to attach, and this will cause the cross bridge formation. So this will be causing the cross bridge formation between the myosin head and the actin. So after that formation of the cross bridge formation, the contraction is occurring here. So over the time, when the ATP is completed, so this will cause the breaking of the cross bridge. So the ATP is lacking here. So ATP is already converted to ADP. So this will cause the relaxation of the muscle. But how this entire process will be happening here? Basically, your actin will be contains of the three types of the myofilaments. What are those three myofilaments, guys? One is your troponin, and another one is your troponin I or your tropomyosin. Okay, this is your tropomyosin, And another one also we have, that is your drop calcium. Okay, so the drop calcium and your ATP of the myosin will be attached. ATP of the myosin will be attached. This will be forming the cross bridge phenomena. Okay, cross bridge or the sliding will be seen here. So further it will cause the contraction of the muscle. So once the ATP is over, so once the ATP is depleted, so this will cause the relaxation. This will cause the relaxation of the. But how this calcium is released, guys? So the calcium is released from the help of the ryanodine receptor. So with the help of the ryanodine receptor, so the calcium will be released into the sarcolemma. So there is also one of the questions that is commonly asked. If the ryanodine receptor is increased in the body, what it will cause? It will cause the malignant hyperthermia. Okay, it will cause the malignant hyperthermia. So if the patient is untreated with the malignant hyperthermia, there is a high chance of the rhabdomyolysis. Okay, rhabdomyolysis, this can cause, and patient can end up into the renal failure. So very highly fatal condition, but it can be treated immediately with the drug of the choice, that is your IV sodium dantrolene. Okay, via IV route, you can give the sodium dantrolene. So this is the drug of the choice for the malignant hyperthermia. There is another thing that you have to remember, that is your dystrophin. Dystrophin is also one of the protein for your muscle cells. If the dystrophin is completely absent, this can lead to the DMD. What is this disease, guys? This is your Duchenne muscular dystrophy. But the dystrophin is very small amounts only present. It is present, but only in the small amounts. So this will cause the Becker muscular dystrophy. So your BMD, completely the dystrophin is absent. Your BMD is completely like small amounts of the dystrophin only present. So these are the disorders and the formation of your muscle contraction. Next, moving on to your the neuromuscular junction and its action potential. We all know that once the action potential is reaching here, it will trigger to open the voltage gated calcium channels. So once the voltage gated calcium channels is opened, so the calcium will comes inside and will help these vesicles. The acetylcholine vesicles will be excited, that will cause the endocytosis of this acetylcholine. Once the acetylcholine is released, this will cause the opening of the sodium gated channels. Okay, your sodium gated channels will be opened here. So for that, the nicotine or the muscarine receptors will be presenting here. So that will cause the opening of this acetylcholine to place. So this is what happens in the neuromuscular junction. All right. Next, moving on to the respiratory system. In this respiratory system, what we are going to discuss, the most common one is the spirometry. Okay. The first thing that you have to remember is the spirometry. The commonly when you are inhaling and the exhaling at the rate of the 500 ml per second or per breath, that is your tidal volume. So this is your inspiration and this is your expiration. That is commonly seen in the tidal value. What is the residual volume? Residual volume is around the 1100 ml. What is this residual volume? This will be for the prevention of the alveolar collapse. So even though if you want to exhale completely from your body is also, it is not going to go out. It is cannot be washed out of your lungs because it will be preventing of the alveoli collapse. All right. Next, the expiratory, the most of the complete inspiratory reserve volume, whatever you can inhale inside maximum, that is your inspiratory reserve volume. The whatever the which most of your exhale from your lungs, that is your expiratory reserve value. And the volumes is combined, then we have to call as a capacities. The first thing, the total lung capacity, which will be involving entire the volumes of the inspiratory volume, tidal volume, and the residual volume. And the vital capacity will involve only your inspiratory reserve volume and your expiratory reserve volume, and the tidal volume is only involved in the vital capacity. And your functional residual capacity. Functional residual capacity will involve only the expiratory reserve volume and the residual value. And there is a question that using the spirometry, what we cannot calculate. One is your residual volume and the other one is your functional residual capacity. and total lung capacity. Whichever will involve the residual value, we cannot calculate from the spirometry. Okay, cannot be calculated using the spirometry. For this, what we have to use, we can use the different method, that is your body plethysmography test. Okay, this can be calculated by the body plethysmography. All right, this is also one of the question. And next, moving on to the inhalation and the exhalation, how this mechanism is seen. So inhalation basically is an active process. Okay, you need the more energy for this process. How this active process is maintained, guys? Your diaphragm, at a time, your diaphragm and your external intercostal muscles. Your diaphragm is the main organ for the expiration and the inspiration. So along with that, your external intercostal muscles is going to contract together, which will be helping to the inhalation of the air. And what about the exhalation? Exhalation is an passive process. Okay, exhalation is an passive process. In this passive process also, both this diaphragm and your external intercostal muscles is going to relax. So this is what happening in the inhalation and the exhalation. And if you want to do the forced exhalation, so if you want to do the forced exhalation, which will also involve your abdominal muscles and your internal intercostal muscles. Okay, it will also internal intercostal muscle to contract. So this is what happens in the forced exhalation. Okay, this is the basic. And then we are moving on to the pneumotoxic centers. So these pneumotoxic centers, next moving on to the pneumotoxic centers. In the pneumotoxic centers, we have the different types of the centers that will be maintained in the brain. One is the majorly your pons and the medulla is going to maintain. How this is maintained, guys? Remember the mnemonic dive. Okay, what is this dive? Okay, D for DRG and V for the VRG. What are these structures? Here you can see the DRG is the one here that is present here. This is your dorsal respiratory group. So this will be maintaining your inspiration. Okay, so the dive meaning the DRG is going to maintain for your inspiration. And how about the VRG? VRG is going to maintain your expiration. So this both VRG is going to maintain your expiration, DRG is going to maintain your inspiration. And what about the pneumotoxic center and the apneistic center? So the pneumotoxic center will maintain the inhale and exhale in the normal manner. Okay, and also remember your pneumotoxic center is a pacemaker of the respiration. Okay, this is a pacemaker of the respiration. And how about the apneistic center? It will be maintaining your forced breaths. Okay, forced breaths. This will be maintained by your apneistic center. This is what the diving centers of your pneumotoxic center, which is commonly used. Next, moving on to your other one. This is also commonly asked. Let's recall here. That is your GLUT transporters and locations. Okay, where these GLUT transporters are maintained. Let's recall with the mnemonic. Rani Lakshmi Bai. You might all have know that Rani Lakshmi Bai made India. Okay, how can you remember? So the R for RBC and your kidney. Okay, and L for liver, pancreas, B for blood-brain barrier and the placenta, and M for muscle commonly, and I for is the intestine. Okay, I for intestine and also in the testis. And there is also sixth one, that is for the spleen. Where the fructose is involved? Here the fructose is involved in the intestine. So these are the commonly the glucose transporters and the locations. All right. Next topic is your oxygen hemoglobin dissociation curve. Basically, at least if you remember the one side of the shift now, this is commonly you can answer easily. What is that? Whichever is increased, if the temperature is increasing, obviously your PCO2 will be increased, right? And if the PCO2 is increasing, the pH will be decreasing only. So this is the basic thing. The what is the ruling between the ideas that you can remember. So what is the normal value of this? So if the patient is having the normal one, this is at the 25 mmHg. And if this is turning towards to the right side, so it will be having the more than 25 plus. So this is the right side of the shift. And if it is having the left side of the shift, the 25 mg will be not maintained, right? So it will be going to the towards the less than 25 mmHg. So everything that will be less, the temperature is decreasing. Obviously, your PCO2 is also decreased and your acidic temperature inside the body is also decreased. That will be turning the oxygen curve to the left side of the chart. So this is the basic thing that you can remember. One thing, if you remember now and integrate with the temperature will increase the PCO2 and hyperventilation will be seen. If the hyperventilation is going on, the pH will be decreased. So then the decreased affinity of the oxygen will be seen. Okay. Next moving on to the types of hypoxia. Let's see, the most common one is your hypoxic hypoxia. What happens in the hypoxic hypoxia? Basically, your O2 is depleting. Okay, or O2 is absent in this patient. He can't breathe properly or he can't take the breathing properly. What happening? Oxygen entirely is going down. RBC is okay. RBC is present in this patient. The circulation is normal. Okay, he can reach the entire circulation for the each and every tissue. But what is the lacking? The most commonly lacking is the oxygen itself, right? And tissues is also normal in this patient. So this is what the hypoxic hypoxia. And next moving on to the anemic hypoxia. In the anemic hypoxia, O2 is present in this patient, but RBC, the traveling RBC is absent. The tissue is also normal only. And the circulation is also intact. But this patient having problem with the RBC. The lack of the RBC is causing the anemic hypoxia. Next, stagnant or the ischemic hypoxia. What happening in the ischemia? Basically, O2 is present. It can reach everywhere. RBC can travel through the circulation. Tissues can get there properly with the RBC and the oxygen. But the lack is the circulation. Why this circulation is lacking here? Because this patient might be having the atherosclerosis. This patient might be having the artery block, thrombus block. All this can cause in the ischemic hypoxia. Next, hypotoxic, histotoxic hypoxia. O2 is normal only. The RBC is also normal only. The circulation is also intact in this patient, but the tissues can't take. Why? Because the tissues might be having this condition like this. Tissues will be damaged due to cyanide or other poisoning. So that is the problem in the histotoxic hypoxia. All right. Next, moving on to the cardiac center. In the cardiac system also, basically the most of the things are discussed in your ECG only. So here only we are going to discuss about the action potential cardiac cycle. So atria, this is belongs to your atria and this is belongs to your ventricle. In the heart, it will be two types only. Okay, one is the atria having the different action potential, ventricle is having the different action potential. All the action potentials are same only. What we are going to do, we are going to trigger with the sodium and sodium will do the depolarization of the action potential, and after that your potassium is going out. This will be reaching to the repolarization stage again. So, but in the atria, we are going to see only the four phases. One is your fourth phase, zero phase, and the third phase. Whereas in the ventricular, we are going to see the multiple phases. Fourth phase, zero phase, first phase, second stage, and third and fourth one again. So this is commonly seen in the ventricular. How? Let's see. Your sodium is entered into the cycle, which will be causing the depolarization. Okay, it will be reaching at particular point and suddenly your potassium is going out. But once the potassium is going out, so there is an inside of the calcium. So this will be maintained the plateau phase. So the calcium is going inside, potassium is going out. This will maintain the plateau phase. Once the calcium channels will be closed now, once the calcium channels is closed, what happened? Your still potassium is going out. Sorry, still your potassium is going out. That will cause the repolarization back to the stage. This is what the action potential of the atria and ventricle. And next, moving on to the electrical conduction pathway. What happens from the SA node? It will reach to the AV node. SA node is your pacemaker of the heart, right? And it will reach to the bundle of teeth. And from the bundle of teeth, it is going to go for the right bundle branch and the left bundle branch. And from there, it will also reach to the Purkinje fibers. And entire heart will be getting the electrical conduction. And which will be turned to be the ECG pathway. And what are the waves that we have to remember? P wave is for your atrial depolarization. The QRS complex, the entire QRS complex is for your ventricular depolarization. And your T wave is for your ventricular repolarization. This is what the basic thing for the entire ECG. You can watch the videos in my YouTube channel. The two videos is available. Please go through the part 1 and part 2 for your examination. Next, moving on to the JVP pathway. So basically the JVP pathway is only measured the right atrium only. Specifically, we are measuring the right atrium. How these waves are formed. So the A wave is formed here. So the A wave is formed due to the atrial contraction. Once the atria is having its contraction now, it will having the sudden sudden increase in the wave that is seen in the A wave. And after that, the atria is relaxing stage. So there will be again the small descent will be seen. So the small systole here again you are seeing because this of the tricuspid. This is due to tricuspid bulge into the atria. So the C wave, the small wave that is due to seen in the tricuspid bulge. And again your entirely the pathway will be descent towards the down. That is known as your X descent due to ventricular systole because the atria is in the relaxed state only. And again the pressure is increased due to the maximum atrial filling. So that is known as your V wave. And the Y wave is for the emptying of the atria. Again, it is down. But the pathologies that you have to remember, if you see the A wave is absent. The A wave is absent in which one, guys? Atrial fibrillation. If you see the Canon waves, if you see the Canon A waves, C for Canon, C for complete heart block. Okay, complete heart block, it is C. And next coming to the prominent A waves. Okay, prominent A waves seen in the tricuspid stenosis. And the Y descent is absent. If the Y descent is absent, that is seen in your cardiac temporary. This pathology is also very, very important. Next, the pressure loop graph. So the pressure loop graph is also commonly asked question. Here you can see how the pressure loop graph is formed. Basically, once the atrial valve is opened, the mitral valve is opened. So this is going to cause the increased pressure in the ventricle. So the end diastolic pressure will be increased here. And after that, mitral valve will be closing here. After mitral valve is closing, the pressure is increased here and entirely the ventricle is going to, because the ventricular filling is completed here, right? So this has to be pumped outside. So the aortic valve will be open here. Aortic pulmonic valves will be opened here and entirely the ejection fraction is completed here. And after that, your aortic valve will be closed and again the filling will be happening here. So this is what the pressure loop graph. And here the question can be asked, closing this one, or this one. So any kind of question can be asked in this graph. So please look at this graph and understand the concept easily. Okay. Next, moving on to your cardiac cycle. How the cardiac cycle is commonly maintained. So simple diagram that you can remember. First thing that you have to remember, the isovolumetric contraction. Okay, isovolumetric contraction. At this isovolumetric contraction, what happens? Your mitral valve and the tricuspid valve will be closed. So this will cause the S1 sound. All right. Okay. This will be causing the S1 sound. From the isovolumetric contraction, this will be also followed by your rapid ejection fraction. Okay. The blood is from the ventricle is pumped to your tissues and the peripheral sites. And then slow ejection fraction. And then there is an isovolumetric relaxation. Okay, all the valves will be relaxed. In this point, what happens here, guys? Your aortic valve and the pulmonic valve will be closed. Always remember, only the closing valves will be causing the sound. This will cause the S2 sound. Okay. After that, you will be having the rapid filling and the slow filling. So this is how the cycle continued. And again, it will be going to the isovolumetric contraction. This is what the basic cycle will be happening. Isovolumetric contraction, the ventricles will be rapidly ejecting and slow ejection. And it will reach the isovolumetric relaxation, then rapid filling and the slow filling will be happening. So this is how the cardiac cycle will be seen. Here you can see the isovolumetric contraction here. So entire the valves will be going to eject the blood from the aorta and the pulmonary. And after that, the ventricular ejection, the rapid ejection and the slow ejection. It will relax the all the valves. And the ventricles is going to be get filled again, and again the cycle will be continued. Where the S1 and the S2 is formed, at the isovolumetric contraction, mitral and the tricuspid is closed, your S1 is formed. And the S2 is formed at the aortic and the pulmonic valve is closed. So this is in the isovolumetric relaxation. And also here you have to remember the what are the murmurs and when they are occurred. So remember this way: isovolumetric contraction, isovolumetric contraction, and isovolumetric relaxation. So this is your ventricular diastole and this is your atrial diastole. Basically, in your ventricular diastole, most of the murmurs will be mitral regurgitation. Because your mitral valve is closed here. Okay. And your tricuspid regurgitation. And your aortic stenosis, pulmonic stenosis will be having the systolic murmur. Okay. And when they say diastolic murmur, that is commonly associated with the mitral stenosis and the tricuspid stenosis. And opposite to that, atrial regurgitation and the pulmonic regurgitation. Because your pulmonic valve on the atrial valve is closed here. So how the valves is closed and how the pathophysiology is maintained, there only the pathophysiology will be occurred here. So this is, you can remember, if the examiner is asking you the systolic murmur is heard, then you can rule out by the options using this trick. All right. Next, last topic, that is your renal system. And in this system, I'm going to discuss the basic things, how the glomerular filtration is maintained. So this is maintained by these three things, guys. How this is your Bowman's capsule and this is your arterioles traveling into the Bowman's capsule, and how this is maintained. So the first thing that you have to remember, the glomerular hydrostatic pressure. So the glomerular hydrostatic pressure is basically from the arterioles. So this is arterioles, right? This arterioles is going to send the hydrostatic pressure towards the glomeruli. So this will cause the plus 60 mmHg of the pressure is increased inside the glomerulus. And after that, the blood, the whichever is blood is going to suck that. So some of the blood is going to suck back into the arterioles. This is the known as the colloid pressure. This is around the plus 20 mmHg. Next, and from the colloid pressure only, the capsule is going to send some more pressure. Capsule will send back the some more pressure. This is around the plus 30 mmHg. And how to calculate this one, guys? So the calculation of the glomerular filtration will be the glomerular hydrostatic pressure, which is your 60 mmHg, right? Minus your Bowman capsule oncotic pressure, blood oncotic pressure, and your capsule hydrostatic pressure, okay, which is around the okay 60 minus 30, which is around the 10. So the 10 mmHg is the net filtration rate. So the GFR of this patient will be around 10 mmHg net filtration rate. All right. So next one is the diuretics and its action. So basically your diuretics, the first one is your proximal convoluted tubule. At the proximal convoluted tubule, the most common one is your acetozolamide, which is known as your carbonic anhydride. And the osmotic one, here your osmotic will be permeable like your mannitol, which will be activated in the loop diuretic only. And next one is your loop diuretics. Here the thick ascending loop. Here the loop diuretics like your furosemide, ethacrynic acid, furosemide, all these drugs will be here only. That means it is going to block your sodium, potassium, and your chloride. And the next one is your thiazides at the distal region. So at the distal region, it is going to block. Means the sodium and only the chloride will be blocking here. The potassium is blocked in the loop diuretics only. And the last one, the spironolactone drugs or your potassium sparing drug, that is happening in the collecting duct. So these are the diuretics and their action. And the last thing that you can remember this way, and these are the syndromes that is commonly associated. What are those symptoms, guys? This is the Fanconi syndrome. So the Fanconi is affected in the PCT, and the Gitelman is present in the distal. Okay, this is present in the Gitelman. And the collecting duct, that is your Liddle syndrome. And here the Bartter syndrome. Okay, this is your Bartter syndrome. At the region of where, guys? This is at the loop diuretic region. So these are the common syndromes that is associated. And last pathway is your RAS pathway. How the RAS is activated? From the liver, angiotensinogen is produced, and from the kidney, the renin is produced. When these both are combined, activated with the angiotensin 1. With the help of the ACE from the lungs, the angiotensin 2 is converted. This is further going to increase the aldosterone. If the aldosterone is increased, what aldosterone will do? It will increase the sodium and it will increase the H2O. So that further it will decrease the sodium, potassium, and it will decrease the H ions. So that's why if the patient is having the Conn's syndrome, what is this Conn's syndrome? The patient will be having the hypertension, and patient will be having the high sodium levels in the body, low potassium values in the body. Okay, metabolic alkalosis. So this is due to adrenal hyperplasia. So these are the basic important topics. Please don't forget to revise. And last minute, the physiology can be your change. Decide. It is going to decide your score. So please should not ignore these topics. Very, very highly recommended. Please do subscribe and share with your friends. And please do access to our new RR notes. This is the best notes that I can recommend for you. And please do subscribe to our YouTube channel. Soon we are going to update the expected topics and the rapid revision of the other subjects.